Today, a topic that is near and dear to my heart. We haven't spoken about this for a while, but it's revision rhinoplasty. And I recently saw multiple patients that required a revision rhinoplasty. And I think what I wanted to do is kind of go over some of the indications. I want to set some realistic expectations, go over the potentials of what you should ask your surgeon, what to expect preoperatively and postoperatively, and how we can change the trajectory of the outcome, because ultimately you don't want to undergo the same surgery again and have a very similar result.
This is an important topic because it's a real topic in the sense that this is probably the number one procedure that has the most revisions. Mm-hmm. And interesting part is I don't do rhinoplasties because of that. And the hard part is one of those procedures that no matter how perfect you do it, sometimes it's not going to come out the way you want it to. And the reason for it is because you're dealing with multiple different structures, meaning bone, cartilage, skin, soft tissue. And each person is different in the sense that skin's thicker, thinner, so forth, so on. I'm going to leave this all for you in a second. And also, it's very difficult sometimes to give somebody what they want if it's impossible, if that makes sense what I'm saying.
Yeah.
So, I'm going to kind of let you run with this and I'll just intervene every now and then.
Over the last several years, there have been about 40,000 revision rhinoplasties that are performed a year in the United States. And there's a slight increase in number. And I think some of that has to do with social media and seeing what's out there. And I'm going to give you at least some of the statistics that are associated with this. So when you look at doing a primary rhinoplasty, 90% of patients are satisfied, and there is about anywhere from a 5 to 15% revision rate, right? This is, of what has been reported. Now, I am imagining that the revision rate is slightly higher in those that are inexperienced. And, I think there was one study that showed up to 40% revision rate.
Wow.
On someone who's out of practice for the first 5 years. Not saying that's all comers, but, this was one particular study. And the success, 90% success in a primary drops to 60% when you're performing a revisional surgery. Okay. Wow. And there are multiple issues at play for that. And we'll kind of go into those. From multiple studies that I've read, there have been zero differences between closed and open as far as revisional rates. And, so if you're going to a surgeon that only does closed rhinoplasty, they're going to have about the same revision rate as someone who only does open rhinoplasty. I tend to do both open and closed depending on what is indicated. And you're going to read about preservation rhinoplasty and structural rhinoplasty and all different types. Ultimately, what really is going to determine is the number of rhinoplasties that are performed by the surgeon and you looking at their aesthetic. That means you look at the before and afters, you see if you like it, if you don't. Some people like something that looks a little more overdone. Some people like something that's a little more natural. And so those are some things, obviously, I am including in there that the person must be a board-certified facial plastic surgeon or board-certified plastic surgeon that is experienced in rhinoplasty. It helps to be, a member of the Rhinoplasty Society because you need to do a certain number of those each year to become a member. And if you are undergoing a rhinoplasty, make sure that your surgeon does a lot of them because, as Dr. Danielpour had mentioned, it can be very tricky. Cartilage can warp. There are scar tissue forces can overpower, grafting and all kinds of things. And thick skin and extremely thin skin can pose multiple issues, right? So from what I've read on the Real Self platform, it does say across the U.S., the average revision rhinoplasty is 11,800. Okay, and that goes from Middle America all the way to here to Beverly Hills. Obviously, some of the prices get a little higher, and I think some of that has to do with surgeons that only do noses or that's one of their specialties, and you see a lot of people. And what I will say is that there are key indications. So let's say for those of you who had a rhinoplasty, and you can't quite put your finger on it, but you're just not happy with it. I'll give you some of the most common reasons for why that is.
Before you do that, can I ask you one quick question? Is there a actual time that is like you have to wait a certain amount of time before you have a revision? Because I think that's one of those things, because some people look at their nose and like, oh my God. And we know it takes a long time for that nose to get that final shape and structure. How long do you normally wait before you do a revision on someone?
As far as timing, the idea, it's a traditional standard that a revision rhinoplasty should be performed at a year or later. Now, that doesn't mean if there are some minor things that can be easily corrected earlier on that it can't be done. Meaning after 3 months, if you notice that one of the nasal bones, the osteotomy hasn't narrowed a nasal bone so it looks asymmetric, that you can go back in and do a minor procedure where you narrow that nasal bone, just so the patient isn't under distress for another 9 months. The other thing is if there's asymmetric nostrils, because one, let's say there was an alar-based resection and one is larger than the other, a quick fix under local anesthesia obviously is to just reduce the size of the nostril. Perfect. And again, I would say you can do that anywhere from 3 to 6 months. The indications for this, you can't quite put your finger on it, but I'll say some of the most common things. One is a slight residual hump. Okay. 2 is widened nasal bones. And sometimes what you do is you see something called an inverted V deformity. And what it happens is the nasal bones are excessively wide while the mid-vault, which is cartilage, the mid-vault of the nose, which is the very middle of the bridge, is too narrow. And so you see that step off and you can see what's called an inverted V deformity. For those of you who have thick skin, my goodness, it's one of the most difficult and challenging noses just because you have to imagine, I always give the analogy that you can put a silk sheet over a chair. And if I bring you into the room and say, what's underneath the silk sheet? You'll say, it's a chair based off of the height and the dimensions. If you take a very thick down comforter and you put it over a chair and say, all right, what's underneath? You might not know what that is. That means the surgeon can create the perfect construct underneath, but you can't see it from the outside because you've got a few millimeters of very thickened, meaty skin. Right? And so there are some things that we can do to help that along, but at the same time, those are the cases where you have to be patient and you wait closer to a year or more for that revision because a lot of times it's just due to swelling. Imagine it's a thick, wet sponge and you're waiting for it to thin and dry, right? One very common thing is called a polybeak deformity. Sometimes what happens is not enough support is left in the tip. And so we lose some of that tip projection and support. The columella, which is the area between the nostrils, tends to hang a little bit. And there's a little bit of fullness just above the tip. So we call it a polybeak because it looks very similar to a bird. And so these are some of the things. Now, obviously, we can throw in some functional components in there. People who all of a sudden, they can't breathe, or there's scar tissue in the nose, or the turbinates suddenly are enlarged, or something wasn't completely corrected. And now you have to imagine if we're taking a larger nose that has a small defect in breathing, and I make a smaller nose, what do you think happens to that defect? Now it becomes much more prominent. So the idea is the surgeon has to plan accordingly to fix both the inside and the outside of the nose. So we talk about common characteristics. So the first thing I'm going to say is this. You have a revision rhinoplasty. And I'm fully transparent. I'd be lying if I said I didn't have my own complications. The idea is I think I follow the standard of having a 5% revision rate. And with revisions, sometimes that goes up to 10%. And the idea is that every time you operate on the nose, you accumulate scar tissue. And scar tissue can do amazing things on every single individual. Okay? So there are a few things that you should look for when undergoing a revision rhinoplasty. So one, you have to feel comfortable that your surgeon is capable of doing it. They have to do a lot of revision rhinoplasty. And so if there are surgeons in Beverly Hills, they only do primary rhinoplasties. They do not do revisions and they refer out for those. Which sounds like a great and very easy practice.
It's like revision breast surgery. It's a nightmare.
It becomes more difficult. And so, first of all, you want to look at the before and afters of someone who's undergone a revision rhinoplasty. The second, you want to make sure that your surgeon feels comfortable doing what you're doing. If they are saying, I don't really see, and that's a tactic that some surgeons use. They say, I don't really see what you're talking about. Now, within reason, sometimes if something's off by a millimeter and you're unable to leave the home, that is not an appropriate response to your surgery. And so you need a preoperative discussion with your surgeon. You have to say, look, here are my expectations. Can you meet those? And if not, you may have to seek out another surgeon. And it doesn't mean the surgeon did anything wrong. Again, if rhinoplasty revision wasn't so common, it would be the fault of the surgeon. But you have to understand there are multiple tissues. You have mucosa on the inside. You have skin on the outside. And in between, you have bone, soft tissue, fat, and skin with cartilage. The idea is you're shifting and replacing all of these different things. Now, whether you use preservation, whether you use structural, you're all altering the innate structure of the person's nose. And so I don't know that one has any lesser complications than the other, although they may have less of a certain type of complication. All right. Mm-hmm. So if you have a large hump and you're a candidate for preservation, dorsal preservation rhinoplasty, sometimes that's the best option for you because the bridge or the dorsum is going to be smooth after surgery. Now, if the surgeon isn't very experienced, you will have a residual hump on the nose, almost like it reforms because enough wasn't done. So it's something you also be careful for. As far as preoperatively, the surgeon who's performing your procedure needs to go over several things with you. We want to reduce salt intake. We want several homeopathic medicines to reduce bruising and swelling. So I always recommend arnica and bromelain. Sometimes we add an NAD supplement just because, a surgery is surgery. You undergo, it's like you got hit by a Mack truck and we're trying to help you heal. Your body's in overdrive. And so sometimes you can use a little extra boost. Then what the surgeon needs to discuss is what's going to happen in that procedure. Many times what happens is your cartilage has been removed, altered, you use Rob Peter to pay Paul, switched around. And so if you need or require appropriate support, it's got to come from somewhere. If you don't have it, then they have to get it from somewhere. So either it's going to be ear, your rib, cadaver rib. And in my practice, I probably do, half and half autologous, which is your own rib versus cadaver rib. In minor cases, you can use the ear, but I'm not a huge fan of it just because it's curved, it's flimsier, and usually if I need some support, I need something rigid and straight.
They do it because it's easier.
Yeah, definitely. And
Most people will take ear cartilage because it's an easier thing to do, and the harvest is a lot easier.
Yeah.
Nice thing is Dr. Layke does so many of these for other surgeons as well that if he needs it, he just grabs it, and it's not an issue.
Yep. And so you want that discussion. Do you require extra cartilage? Are you going to be placing grafts into the nose? What will I require? And then, where are we getting this from? My general rule of thumb is if I only need a little bit, I usually take it out of the package, cadaver rib. It's stripped of all cellular elements and your body grows into it. But if I have to fully reconstruct the nose, I'd rather have your own cartilage to a point. Meaning, once you approach your 50s, and if you're having a revision at that time, sometimes the cartilage becomes very calcified, and then it's not worth undergoing the incision and harvest and things like that for a piece of cartilage that's probably not going to be that great anyway. And then after surgery, I think you need appropriate bolstering. So I tend to use what are called suprahilar splints. I use splints that go in along the septum. I use a hardened thermoplastic nasal splint on the outside. The whole idea is to try to reduce dead space so no blood can accumulate, no swelling can form, and it keeps the nose into the shape that you want it. Many times, people come to me and they have twisted cartilage, a lot of scar tissue. The tip doesn't look normal, and the skin has memory. The thicker the skin is, it has memory. It wants to go back to the way it was before. It's the most amazing and frustrating thing. And so that's why we require that support. After that 1 week, everything comes off, and then your surgeon's going to do what they do. I would recommend at least traditional taping. In our practice, we use a three-dimensional splints from Mirror Me 3D, which are custom splints based off of the vector simulation that we create. And so obviously the surgeon has to get as close to that simulation as possible so the splints fit. Post-operatively, again, what we're going to do is say avoid alcohol, salty foods, fried foods, anything that's going to lead to swelling. Your head's going to be elevated. We have a cleaning protocol, everything that is going to, make sure that you have the best possible result. And then, especially if you have thickened skin and in rhinoplasty, sometimes even in a primary, but in a revision rhinoplasty, we do steroid injections because the goal is to eliminate as much scar tissue as possible. We already know that there's scar tissue there from the original surgery, but you're going to accumulate some afterwards. And so, these are all things that you should definitely expect. Again, I just want to go over the fact, the important things is, one, the revision rate in a primary rhinoplasty is anywhere from 5 to 15%. In fact, the Aesthetic Surgery Journal reported 10%, and that's inexperienced surgeons, okay? And there was another study that was reported that was up to 40 to 50% in an inexperienced hands. Wow, so you just want to make sure that you do a lot of them. Your surgeon does a lot of them. And then once we get into that category, the success rate in a revision drops from 90 to 60%. And that sounds like a massive drop, but sometimes, and you have to imagine, that's in all comers. That means from secondary, tertiary, quaternary, each time it drops further because it's very, very difficult. After someone's had 4 rhinoplasties and the nose does not look normal, there are a few surgeons on the planet that can fully reconstruct your nose like that. And so the idea is you want to make sure that you go to one of them. I think that the most important decision that you're going to make is having that conversation with your surgeon. Are you prepared? Do you feel like you can do this? And I hope to God they're honest with you, because I know I would be. If there was something that I feel like if I move forward, it'll be detrimental. And I can, again, I feel like I can reconstruct the entire nose. And so, we've created noses out of forehead skin, a skin graft for mucosa, rib cartilage. Again, I've done it all. But these are very tricky surgeries. And so they have to be aligned with your expectations, set realistic expectations, and then be prepared to fully reconstruct the nose.
No, it's difficult if it's someone else's nose that comes to you. If it's a revision you're doing for someone else, it's a whole different story.
Sure. Than
if it's your own. That's why Dr. Layke is sitting here telling you about how prepared you have to be, not because of any other reason than you don't know what they did before.
Yeah.
So you have no idea what's going on, and you're going to open up this nose, and it could be a mess. And like many times I walk in and see you're like, wow, this is a big mess. So revision rhinoplasties, like we're saying, you need to be ready to just do just about anything and everything that's thrown to you with a blind eye, in a sense. You don't know what's going on.
I always ask for the previous operative reports, but sometimes you can't get them.
Exactly.
I mean, it's something that was done 30 years ago. Anything over 7 years, a physician doesn't have to, keep those charts. And so, we obviously have kept everything from the beginning of practice, but the idea is that you might not have that roadmap. And, I've read operative reports where I get in expecting one thing and I don't see it. Yeah. So, and it's not that they didn't do it. It's that sometimes, let's say they put in a graft that was completely dissolved or chewed up by the body. And now that's the reason for the loss of support. So you kind of have to do something a little different, and again, this is why revisional rhinoplasty is so tricky. And
the hardest part about this operation is this. I do a lot of breast and body surgery, liposuction and tummy tucks and breast. And 90% of the time, people's clothes are covering their results. So they're not staring at it in their face. Yep. And what I've noticed more and more over the last 15 years of practice, I can't believe it's going to be 15 years in a couple months, but is that people are so obsessed and they're so fixated on having their phone like this to their face with all the different angles, where it's frustrating because as surgeons, there are going to be angles that you're going to take pictures of yourself or you're going to bring up a selfie that's just not going to look good.
Yeah.
And that's the one thing I want to stress to everyone out there that's listening. Guys, it's not going to be perfect. People come up to us all the time. They sit down, they bend over, they're like, can you get rid of this skin? I go, well, what about standing? Or they'll bend their neck over like this. Can you make it better even after a left neck lift? You have to be reasonable.
Yeah, I think the problem with social media is that they have made unrealistic expectations.
It's horrible.
Semi-realistic.
Especially for young girls. It's the worst. I mean, it's just...
There are inherent things that will happen to an average individual that might not happen to someone on Instagram just because of body composition, genetics, and all kinds of different things, age, and filters. So, again, you got to be very careful about this.
So 2 questions, if I was a patient, I would want to ask. And this is something I would tell people to ask. Number 1, when do you normally tell people, hey, what you see is what you get? Like the swelling's gone, the shape is there. Yeah, there's not going to be a significant change anymore.
I say for people who have relatively thin skin, I say it's usually around 10 to 12 months. And then I say for people who have moderately thick skin, that it's going to be, that 18-month mark. And for people with thick skin, all bets are off. That can be 3 to 5 years after. And I know I don't want to, cause any frustration in anyone, but you have to understand that there are certain things that we cannot change. If I'm looking, it's one good thing about doing open rhinoplasty. I can look at the inside of the thick skin, and if there's a little layer of fat, I take that. It's under the SMAS layer, or the superficial muscular aponeurotic system. And if I can take that, yes. If you get more aggressive, you'll kill the blood supply, and you're gonna require much larger surgeries than this rhinoplasty.
Absolutely.
So the idea is there's only so much you can do while maintaining safety, and so the surgeon has to. And I still have those patients. I fully tell them, we go over and over and over on how we're not going to see the results that we want early on. It's going to be later. And they'll come back afterwards and say, but it's still swollen right here.
Yeah.
And you'll say, okay, but again, it is important for the surgeon to try to relay that as best they can.
And the second question is, if you're doing my rhinoplasty, primary rhinoplasty, and I need a revision, how does that work? Do I pay you the same amount? Do I pay you more? Is it free? Like some people are like, well, you did it. You have to do it for free.
Yeah, listen, that's a very important question. It's something that you should ask when you are going for your primary rhinoplasty. You just say, look, if it doesn't work out, what are my next steps? I always say the same thing. Point. I'll take you back to surgery. I'm obviously not going to charge you a surgeon charge. You are responsible for the operating room and anesthesia. Those are separate costs that I have to pay for. And sometimes you have to imagine that, again, it's a different ballgame if we get into a primary rhinoplasty and I cut the tip of your nose off. That's a whole different ballgame, right? But if for some reason the cartilage warps and something bends, or there's excess scar tissue and things that we can't manage with steroids, that's the way your body healed. And so again, I'm still doing each operation the best I possibly can. Sometimes it just doesn't go my way.
And that's really important. And there's something that we use in our practice that we didn't from the beginning, but the busier we got, the more we realized that people are, especially in our area, and Beverly Hills is very different than the rest of the world.
And I recommend it to all younger surgeons out there, any surgeon out there, really.
So we use an insurance, basically. Now, there's a couple different ones. ASPS has Cosmetic. We use BlissCare. One of the surgeons I know said that they use it. And I think it's an extra like $200 or $300 charge on your total rhinoplasty or breast augmentation or whatever surgery you're having done. And that gives you an insurance that if you do have to have revision surgery, it's either very, very discounted or it's, you don't have to pay anything. And I think it's good because when you have a possibility of having 1 in 10 people needing a revision, then I think you're getting that insurance and it does help. So that's something to kind of think about.
Yeah.
But it's a reality that revision surgery in plastic surgery is real regardless. We're not saying that, something happened to your nose, it's interesting because we were just on the show, The Valley, and Dr. Layke did a rhinoplasty on Jax, who's one of the stars on the show. And on the show, they're like, well, he had 4 rhinoplasties. Well, first of all, just to clear that up, he didn't have 4 rhinoplasties. And the only reason he had any revision rhinoplasties is because he walked into a plate glass window and actually broke his nose
3 weeks later,
had multiple stitches and needed to have it fixed. So sometimes a revision is caused by an injury or trauma. That's not a surgeon's fault. So let's get that out of the way. And the other thing is, if you're having a revision just because you don't like it, but you've had this discussion with your primary surgeon and the results that he's given you are right on point, well, that's more of an issue that I think you need to kind of think about.
Yeah, I think more often than not, what I'll find is that as someone who has relatively thick skin, they want the nose to be narrower, smaller, whatever it is. And you have to understand that you have to create a construct underneath that there is a minimum size that you can trim the cartilage.
So you can breathe.
You
need to breathe.
And so it doesn't collapse. And we saw that in Michael Jackson. They tried to go thinner and thinner and thinner and thinner. And then all of a sudden, it's completely collapsed. So I want you, for those of you that are out there like that, you have to keep that in the back of your mind. There's a limit to what it can do before it falls apart. And so, I always try setting expectations at the beginning, saying, look, we're going to make it as narrow as we possibly can. If I made a tip, which arguably for a female should be 8 millimeters between the 2 cartilages and a centimeter in males, if you've got a 3 millimeter thick skin, add 3 millimeters to both sides.
Absolutely.
Now for a male, you've got 16 millimeter tip, and in females, you've got 14 millimeters. Of course, everyone wants to go narrower,
right?
But the skin is the limiting reagent right there.
It's amazing. Honestly, for everyone who's thinking of having a revision surgery, I think it's good. Number one, I do, if it's, you don't want to go back to your surgeon, go to a couple of them.
Yeah, definitely. I agree with that. I mean, I think I wanted to touch on one point. There is one potential option for those with thick skin. You could make the nose longer, and it will somehow, it will slightly stretch the skin ever so slightly so that you can get a little narrower then. But it's not my aesthetic. I know that there are surgeons who do that where they make it
very snouty though.
They make it a little longer, and that will, it's like setting a tent pole. It'll, stretch it up a little bit. That's just not my aesthetic. So
that's interesting though.
But I agree with you. See multiple surgeons.
Go see a couple people because you want to. The whole thing is, and we've talked about this so many times on our podcast. When you have plastic surgery, you want to be comfortable with your plastic surgeon because if you don't like something, you want to be able to say it. And I know there's a lot of plastic surgeons out there that basically will dismiss their patients.
Yep.
John and I are not those guys. But it does. Again, I'm not advertising. I'm just saying, find someone that is going to be able to listen to you.
Yeah, 2 things. They gel with you because they're going to be friends for a long time. And 2, you make sure that their aesthetic matches yours.
Absolutely.
So when you look at the before and afters, don't pick out one, and if the rest of the aesthetic is something different. You look at the overall aesthetic and say, all right, is this something I prefer or I don't?
Absolutely.
If you like this video, you're going to love this one.
You have to know your anatomy very well. And that's why it's very important that you go to somebody who knows the anatomy that they're injecting, because anyone can inject this. But to do it properly is a different story.